Hello, this is Andre, and today I'm going to discuss infantile hemangioma, and this lesion is a part of my lip lesion series. Hemangiomas are defined as a benign vascular tumors that arises due to an abnormal proliferation of endothelial cells, which, as you all know, are the cells that line the blood vessels. While their etiology is not completely understood, a combination of genetic, molecular, and environmental factors is believed to contribute to their development. In children, the lips are a common site for them. Their location on the lips may be influenced by their rich vascular supply and active angiogenesis during the early development. Their prevalence is about 4 to 10% in infants by the age of 1 year. They are more common in Caucasian infants compared to other racial or ethnic groups. And also, it has been found that there is a higher incidence in premature infants, especially on those with a super low weight, like under 1500 grams. It is important to note that most hemangiomas are absent at birth, but they may appear within the first few weeks of life. They tend to grow rapidly due to the hyperplasia of these endothelial cells during the first 6 to 12 months, which is known as the proliferative phase. And their involution typically occurs between the ages of 1 to 7 years, with a complete regression in most cases by 10 years. What happens in this stage is that we are going to find a gradual regression of endothelial cells that are being replaced by fibrofatty tissue. Here are the 5 top factors that may contribute to infantile hemangioma. First, we have genetic predisposition. Genetic mutations or predispositions can influence the development of this type of hemangiomas. Mutations, especially on genes like GNAQ and GNA11, that are involved in signaling pathways for vascular development, are affected. Then we're going to find the angiogenic and growth factors. Here we're going to find elevated levels of angiogenic factors like vascular endothelial growth factor VEGF and basic fibroblast growth factor BFGF, which are going to stimulate an excessive blood vessel formation. Third, we have hypoxia. This theory is supported by the common occurrence of hemangiomas in premature infants, where hypoxic conditions during the fetal development may upregulate angiogenic factors, prompting the growth of this lesion. Then we have hormonal influence. Hemangiomas are more prevalent in females than males, suggesting a potential role of estrogen in their development. And lastly, we have immune dysregulation. Local immune responses or inflammation could contribute to the abnormal vascular proliferation. The International Society for the Study of Vascular Anomalies provides a standard classification system for infantile hemangiomas. And here's the breakdown. 1. According to their type. Infantile hemangiomas falls under the umbrella of vascular tumors, as opposed to vascular malformations, which is a different type of lesion. Unlike malformations, hemangiomas are proliferative lesions that actively grow. Then we have the clinical subtypes. Infantile hemangiomas can be classified based on their depth, location, and extent. The superficial infantile hemangioma, they are also known as strawberry hemangiomas, appears like a bright red and raised on the skin. The deep hemangioma is located under the skin and is going to cause a bluish or skin color appearance. And lastly, we have the mixed hemangioma that contains both superficial and deep components. They could also be classified according to the patterns of presentation, which means that they can also be classified into focal, segmental, multifocal, or indeterminate patterns. Focals means a single or localized lesion. Segmental that involves a larger or defined region, often following a developmental units of the skin, multifocal, multiple, and separate lesions, and indeterminate does not clearly fit into the above categories. Then we have the special variance classification, where we find the phase syndrome of PHACE syndrome that compounds a large segmental infantile hemangioma that is associated with congenital anomalies, such as posterior fossa malformations, hemangiomas of the arterial anomalies, cardiac defects, and eye abnormalities. And then we have the lumbar syndrome, LUMBAR, where the infantile hemangiomas are associated with lower body hemangiomas, urogenital anomalies, bony deformities, and anorectal malformations. And the last classification is according to the risk stratification. And here we have low risk, higher risk. The low risk are the ones that are small, uncomplicated, that are very unlikely to cause functional or cosmetic problems. Whereas the high risk are those lesions that are in critical areas, such as periocular, airway, or large segmental hemangiomas. And these ones have a higher risk of causing complications like ulcerations, obstructions, or syndromic associations. Regarding the pathogenesis, everything starts with the factors that may trigger the development of infantile hemangioma. As I just mentioned before, these may include premature birth, hypoxia, placental abnormalities, or genetic predisposition. This is going to be followed by an abnormal angiogenesis and vasculogenesis. This is the hallmark of infantile hemangioma. The pathogenesis in this case is dysregulated angiogenesis with a formation of new blood vessels and vasculogenesis, which is the new formation of blood vessels from progenitor cells. The key players on this stage are the VEGF and the BFGF, which promotes the endothelial cell growth and vascular formation. After this happens, we have the role of endothelial progenitor cells, or EPCS. These cells originate from the bone marrow and are abnormally recruited to the lesion site. And after all of this has happened is when we have the proliferated phase. In this phase, as I just mentioned before, we're going to have a rapid growth that is going to occur in the first 6 to 12 months of life. And they're going to be driven by elevated VEGF and BFGF levels. These lesions in this case are going to become hypercellular with a densely packed, rapidly dividing endothelial cells that are going to form new vascular channels. And lastly, we have the involution phase that is going to start around age 1. And here is when the hemangiomas are going to enter a phase of slow regression. This is going to happen because the growth factors decrease and the vascular tissue is gradually replaced with fibrofatty tissue, which is going to lead to an apoptosis of endothelial cells.